Thank you, Dr. Weiss. Welcome all to our internal medicine grand rounds. Today is with great pleasure that I present Dr. Jackson Wright. He is a medical doctor, doctorate on pharmacology, and fellow of the American College of Physicians. Dr. Wright obtained his bachelor on zoology at the Ohio Wesleyan University, and then went on to continue his training as a medical doctor in the University of Pittsburgh, where he also completed his doctoral studies in pharmacology. Dr. Wright then went on to do internal medicine residency in the University of Michigan. He has several awards and impressive recognition throughout his career, such as he's a fellow of the American College of Physicians, as I said before, fellow of the American Association of Black Cardiologists, as well as the American Heart Association High Blood Pressure Council. He earned Internist of the Year in the year 2000 by the National Medical Association. He obtained the Dr. Daniel D. Savage Memorial Science Award as by the Association of Black Cardiologists in 2007. He has also been recognized as with a Clinical Research Prize, an outstanding contribution to advancement of cardiovascular science by the American Heart Association, as well as the 2000 Award of Advancement in Health by the Healthcare Heroes Award from Crane and Cleveland Business Magazine. Most recently, he obtained the Mervyn Moser Clinical Hypertension Award, Council of Hypertension of the American Heart Association. Dr. Wright is also a diplomat of the National Board of Medical Examiners, the American Board of Internal Medicine, as well as the Board of Clinical Pharmacology. He is currently an emeritus professor of medicine and director of the Clinical Hypertension Program at University Hospital Case Western Medical Center. From 2001 through December 2015, he served as the program director of the former General Clinical Research Center at William T. Dems in the Clinical Research Unit. His research has focused on the clinical investigation of the pathophysiology and treatment of hypertension, cardiovascular, and renal disease, with publication record over 300 peer-reviewed articles, book chapters, and abstracts. He has had a major leadership role in nearly all the major NIH-funded cardiovascular and renal outcome clinical trials conducted in Black population over the past 2.5 decades. He's also served on multiple national and international advisory panels, including the NIH Advisory Panel, co-chairing the treatment section of the Joint National Committee GNC7 on prevention, detection, and evaluation and treatment of high blood pressure. Most recently, in the US hypertension guidelines published by JAMA, Dr. Wright is also a contributor, and the Annals of Internal Medicine in 2013, and the 2017 ACC/AHA hypertension guidelines. In addition to his own research activities, he's also served as the protocol review committees and data safety and monitor boards for the following long-term clinical outcomes studies involving Black population: the Jackson Heart Study, African American Heart Failure Trial, AHEFT, and the study of tamoxifen and raloxifene for breast cancer prevention STAR study. A major focus of his research has been the many causes of remediation of healthcare disparities, including the enrollment of adequate numbers of minority subjects in clinical trials. He has played a leadership role in many of these clinical outcome trials conducted in Black and minority populations, as I said before. He also served as the PI of the 5 clinical center networks and a site PI in the systolic blood pressure intervention trial SPRINT. So this is going to be a lecture part of the Dr. Barry J. Matterson lecture series. Dr. Matterson is a well-published, widely recognized hypertension researcher and the former chair of the VA Cooperative Task Force on Hypertension. Has established an endowed lectureship in perpetuity to bring leading hypertension experts to medical ground rounds. The purpose of this lecture series is to expose faculty, house staff, and medical students to prominent hypertension authorities to provide the opportunity to posit relevant questions. So as I said before, it's with great pleasure that I present Dr. Wright and his lecture on BP control in the post-SPRINT era.
Well, thank you, Dr. Byer. It seems like I need to pay you well for that wonderful introduction. And it's certainly, I'm sorry, Dr. Weiss, Dr. Preston, and certainly Dr. Madison. Let me say that it is indeed an honor for me to have been invited to speak to you all today at this Grand Rounds, especially the lecture series named after the esteemed Dr. Barry Madison. I've known Barry for more than 3 decades, and of his work as a premier hypertension clinical investigator, policymaker, and leader even longer. In fact, if there is a title, Godfather of Hypertension, it would be Barry's. In addition to his intellect, his training, his integrity, and his leadership, I also early on learned of his not so secret weapon, and that is his wonderful wife, Baruta. So thank you again for the invitation to speak to you. And the plan is to certainly discuss blood pressure control in the post-sprint era. My disclosures are listed here. They are none that particularly affect this lecture. Topics I'll cover is the relationship of cardiovascular risk with blood pressure in hypertension treatment trials. I'll show the sprint results in the US, showing the reduction in clinical outcomes in diverse patient populations, and also review the confirmation of the sprint results from the STEP trial from China. We'll review the data on the tolerability of the now recommended lower blood pressure targets, and then focus on proposed strategies to achieve equitable blood pressure control with the available evidence and rationale reviewed. This represents the current state of national and international guidelines. Now, prior to, say, 5 years ago, the blood pressure of less than 140/90 and even less than 150/90 would be seen on nearly all of these slides, or in all of these guidelines. Today now, as you can see, after the AHA/ACC guidelines in 2017, nearly all of the font that you see now is either red, representing less than 130/80, and you see some blue representing for instance, the Canadian guidelines recommend systolic blood pressure less than 120, but it's fairly consistently now showing blood pressure targets that are recommended by national guidelines appreciably less than the 140/90, and certainly less than the 150/90, even though our professional societies, the family practice, and our own internal medicine professional practices still hold to the less than 140/90, and unimpressively to less than 150/90 in patients over age 60, which I think can no longer be justified. The data comes from these are the data coming out of Sprint. These are the final data. As you know, this Sprint trial was ended by the Data Safety and Monitoring Board in 2015. We published data, and we published the results then, knowing that there were a number of outstanding events. However, it was realized it was doubtful that they would have appreciably changed the results. At the time, we reported a 25% reduction in the primary outcome, with the addition of 108 more clinical outcomes, primary outcomes, and 110 more, in fact, deaths. We now, final report reported out last year in the New England Journal shows a 27% reduction in the primary outcome, and also a 25%, still a 25% reduction in death from any cause, not to mention a 42% reduction in death from cardiovascular causes. There was a CKD component of the trial, but as you can see, the numbers were very small, and so that could not evaluate the effect of blood pressure control on reduction in CKD. In patients without CKD, we did report out that about over a 3.5-fold increase in patients having a 30% reduction in eGFR, but no evidence of long-term dialysis or transplantation. Incident albuminuria was significantly decreased, and the 30% reduction in eGFR was in fact reflects the hemodynamic effect of aggressive blood pressure lowering with the addition of with the use of diuretics and RAS inhibitors. Importantly for the primary outcome, if you look at the forest plot representing the outcomes in both the pre-specified subgroups, age above and below 75, male versus female, Black versus non-Blacks, with or without CKD, with or without prior CVD, and blood pressure tertiles, as well as the not pre-specified, but since we had the evidence, the outcomes in by race, ethnicity, the frailty versus fit, patients with and without the metabolic syndrome, and even in patients with and without prediabetes. What you see is that a very tight forest plot showing that, and no evidence of an interaction, meaning that essentially all of these subgroups appear to respond similarly. Also, the same holds for the subgroup analysis for all-cause mortality, again showing very tight forest plot. The group in Hispanics appears to show an increase in all-cause mortality, but in fact, if you looked at the hazard ratio for cardiovascular death, in fact, it was down. It would be a 0.17, and so that the apparent increase in mortality was secondary to non-cardiovascular mortality. Since the publication of SPRINT results, the STEP trial from China was published. The SPRINT trial had over 9,200 participants. The STEP trial in China had about 8,500 participants, while the SPRINT trial compared systolic blood pressure targets of less than 120 compared to the less than 140 in patients over age 50. The STEP trial compared a systolic blood pressure of 110 to 130 compared to the target of 130 to 140, and age range 60 to 80. So both of these trials had clearly provide evidence in patients that patients over age 60 should be treated to much lower targets than a 150/90. And in fact, the evidence that I'll show suggests that even more importantly, they should be treated to data, or even more impressive in older patients, to be treated to the lower blood pressure targets. This is the result shown here. Is a meta-analysis, network meta-analysis that shows that. Let's see, let me get this out of here. Okay, network meta-analysis showing that a stepwise reduction in cardiovascular events in patients treated to lower blood pressure compared to those treated to higher blood pressures in randomized controlled trials. Here, less than one reduction compared to treating to less between 120 and 124. As you can see, at higher blood pressures, in comparing the lower blood pressure to higher blood pressure, you see a stepwise reduction in cardiovascular outcomes. And these are clearly well below the current US and European guidelines. Findings are similar for stroke, coronary artery disease, and all-cause mortality. Sensitivity analysis, even if you do not include SPRINT, that the results are the same and fairly consistent in multiple meta-analyses showing fairly similar data. One thing that we were able to show in SPRINT 2 was the question of the J-curve was we were able to evaluate since we had patients. These are patients who had baseline diastolic blood pressures and looked at the effect of the treatment target intensive, the less than 120 versus less than 140 in patients based on baseline diastolic blood pressure. And as you can see, for the primary outcome, again, these would be patients. This looks at the event rate, and there's no suggestion of a J curve, even in patients, even at lower diastolic blood pressures, and we go down to less than 68. As you can see, there's no suggestion that those patients with initial diastolic blood pressures below 70 have are at increased risk with aggressive blood pressure lowering. The same holds for all-cause death. Incident CKD, the 30% reduction in EGFR again was associated in that analysis with a higher rate of incident CKD in patients randomized to the intensive target. But again, that has been shown to be explained by a reversible hemodynamic effect of the systolic blood pressure reduction on EGFR. The SPRINT trial also had a mind component where we looked at cognitive decline, and actually when we looked at the incidence of mild cognitive decline, that was significantly reduced in patients treated to the less than 120 target versus the less than 140 target. There was a reduction in confirmed dementia also, even though that did not reach statistical significance. If you remember, the trial was stopped early, only 3.3 years rather than the 5 years that was that the trial was designed for. And so that certainly the number of events was insufficient to fully test that. But when combined with other blood pressure lowering treatment trials, looked at dementia occurrence within SPRINT Mind, in SHEP, Progress, HIVAC, and the meta-analysis did show a significant reduction in confirmed dementia in patients treated to the lower blood pressure target. In terms of tolerability, if you looked at the SAE reports in SPRINT, there was essentially no difference in serious adverse events in patients randomized to the intensive compared to those randomized to the standard. As you can see, hazard ratio right around 1. And even in patients over age 75, there was no difference in SAEs, even though there were, in fact, a large number of SAEs in the population overall based upon risk, but there was no difference in adverse events, SAE events in patients based upon treatment arm within SPRINT. The data, adverse event data from the STEP trial also, again, shows essentially no significant difference in the adverse events that were reported in the STEP trial. So again, showing this, at least the safety of the treating to the lower blood pressure target. Again, these are in older patients. And then we have the quality of life study that looks at additional evidence of tolerability, again, showing no difference whether you look at the physical component, the mental component, or depression scores in the VR12, showing absolutely no suggestion of difference in tolerability of whether patients are treated to the less than 120 or the less than 140 target. The finding that I think is just as important as the fact that the patients did better and were safe is the fact that could the blood pressures, in fact, that were designed within the SPRINT protocol, could they in fact be achieved? And as you can see here that yes, they could be achieved, and generally somewhere between 3 and 6 months. The blood pressures were certainly reduced in both the standard arm to less than 140 and in the intensive arm with and could be maintained throughout the duration of follow-up. The average achieved blood pressures, if you include all the blood pressures, were 121 in the less than 120 arm, 136 in the less than 140 arm. This compares in the STEP trial, the blood pressures were in the 110 to 130. The achieved was 127 again versus 136. So that again, you can achieve these blood pressures within the trial. Now, one difference between SPRINT and the STEP trial was the diversity within SPRINT. The STEP trial was done in the Chinese population, and only actually one ethnic group, the Han ethnic group within China, does make up 90% of the Chinese, but certainly rather uniform population. Whereas in SPRINT, there was had substantial diversity. One, in addition to it being an older patient population around age 68, 28% of the patients were over age 75. Gender here, 35% were in 35%, 36% were female. In addition to about 57 to 58% were white. Blacks made up almost 30% of the population, almost 11% were Hispanic, as well as by different categories of risk. 90% of the patients were taking antihypertensive medications. So that a very much more diverse patient population within SPRINT. Here again, we were, it's indicated, we're able to achieve the blood pressure targets within SPRINT. did require in the standard arm about two medications, 3 in the intensive arm of the trial. But shown here is the achieved blood pressures that were reported within the trial. This was reported out this year, and in fact, 61%, almost 62% of the patients randomized to the less than 120 target were in fact less than 120 overall. In the standard group, where patients were treated to less than 140, the 71% of the patients were in fact were able to achieve the less than 140 target. But one of the other is that, as shown here, the 80% of the patients who were randomized to the intensive arm were able to achieve a systolic blood pressure less than 130. So bottom line is that clearly the trial shows that the less than 130 target recommended in current guidelines are in fact achievable. They can be achieved within SPRINT. These percent control rates to less than 130 should be able to be achieved within the clinical practices that we are dealing with. One of the issues, there are a number of quality improvement projects that have been initiated, and they've shown success in terms of increasing the blood pressure control rates. And these are blood pressure control rates to less than 140 over 90. Don't have a good quality improvement data yet on control to less than 130. But as you can see, there is a significant increase in control rates over time with these quality improvement projects. However, in nearly all of the quality improvement projects that have been published, what you see is also a gap in control rates between Black participants and white participants, and it generally runs somewhere between 5 and 10%. Now, this was shown in this here, the Kaiser project. These are data from the MAP program, Measure Accurately, Act Rapidly, and Partner program out of the AMA. Again, showing that if you look at hypertension control rates, they are to the control rates in Blacks versus whites. Again, you see about a 5 to 10% lower control rate to less than 140 over 90 in Black population patients compared to the non-Blacks or white patient population. A key element of the before I get to this report here, these are data from SPRINT. Okay, and what this looks at is this represents the, as we said, the median achieved systolic blood pressures within SPRINT was about 121 at the in those randomized to intensive arm, 135 in those randomized to the standard arm. Now this is from baseline to the end of the trial, which means that this also includes the early phases of the trial where blood pressures and medications were being titrated. If you go the median follow-up after 6 months, the end of the titration period, again, showed that we could actually, the average blood pressure after the 6-month titration period did average less than 120 in the intensive arm, and still about 136 in the standard arm. Steve, a good data. But importantly is the fact that these values were achieved in nearly all of the subgroups that were both the pre-specified as well as the not pre-specified subgroups, so that by metabolic status, shown here is the fact that even in those patients, even in Black patients within SPRINT, we were able to achieve the less than 120 target with no difference by race within the SPRINT trial. Now, the classic treatment and the treatment algorithm in most of nearly all of, even today, the quality improvement projects that are going on in most practices is to start with the utilization of fixed dose combinations. That's generally low dose ACE or ARB diuretic combination, titrate that up to maximum dose, and then add additional medications to achieve the blood pressure target, along with obviously lifestyle encouraged self-monitoring of home BP, et cetera. So that, but clearly utilize fixed dose combinations of these agents. The challenge there is that, this is from a number of practices that we are doing a quality improvement project in the Medicaid population within within the state of Ohio, shows the use of different antihypertensive agents. And I guess what I want to show here is the fact that most patients who are treated with diuretics are in fact on either 12.5 or 25 milligrams of hydrochlorothiazide. Very few are treated on the 25 and certainly 50 milligrams of hydrochlorothiazide. Chlorothalidone use in practice, and we've seen this in multiple surveys. Generally, less than 10% of patients are being treated with chlorothalidone. About the same as are receiving clonidine, unfortunately. So that the typical diuretic dose used in clinical practice, and in fact in fixed dose combination products, there are only two that in fact include chlorothalidone, the atenolol chlorothalidone combination, and a new non-generic azilsartan ARB plus chlorothalidone fixed dose combination. But otherwise, other agents used in fixed dose combinations utilize, if you want to stay with a single pill of the fixed dose combinations, you cannot receive a higher dose of hydrochlorothiazide. 25 is the maximum dose that you're able to utilize, unless you go to 2 or more tabs, which essentially defeats the purpose of the fixed dose combination. These are data from our center, one showing that it is doing this is earlier data prior to the initiation of our quality improvement project. About 67% control to less than 140 over 90. This was probably data from about a year ago. Only about a third of the patients were in fact controlled to less than 130. Again, with a black-white gap in control rate, patients with diabetes, patients with CKD shown here. But what I wanted to show is on this next slide, and that is obviously treatment intensity is a challenge. Both these data as well as in the Medicaid data that I showed earlier, very few of the patients are on. These are in patients whose blood pressure is elevated These are not in patients who are controlled. This looks at the medication profile in those patients. Less than 50% of the patients are on 90-day, more than 30-day refills. Only 1 to 2% or 3% of patients are on 3 medications. In those patients who are not controlled, spironolactone use is relatively low. Chlorthalidone use is here. Again, either percent of patients receiving either chlorthalidone 25 or 50 of hydrochlorothiazide. Generally, you're talking about certainly 3 to 7%. So that there are certainly opportunities to increase control rates in those patients who are not controlled. The reference to the low-dose hydrochlorothiazide that is being used in practice, I think, is reflected on this slide. This looks at the diuretic doses that have been used in the morbidity mortality trials, going back to the VA cooperative trial. In fact, used up to 100 milligrams of hydrochlorothiazide. HDFP used actually 25 to 100 of chlorthalidone. As far as hydrochlorothiazide, the doses generally were either the lowest was 25 to 50. There's only one chlorthalidone shown here, 12 to 25. So we have good data on the 12.5 to 25 of chlorthalidone. The only trial that used 12.5 to 25 of hydrochlorothiazide it was in the ACCOMPLISH trial. In all the other trials, the diuretic arm showed a greater reduction in cardiovascular events. In this trial, the 12.5, 25 of hydrochlorothiazide, along with the ACE inhibitor, was compared to amlodipine 5 and 10 milligrams plus the ACE inhibitor. And in this trial, it's the only trial where, in fact, the diuretic arm of the trial was not successful, showed a lower reduction in cardiovascular outcomes compared to its comparator arm of the trial. So that we have good data on 25 to 50 or 25 and above doses of hydrochlorothiazide on its ability to prevent cardiovascular outcomes. We do not have adequate data or the data and suggestive data that the 12.5 25 that is currently being used in clinical practice is not as has limited lesser benefit in reducing clinical outcomes. In terms of chlorthalidone, we have great data on chlorthalidone. In fact, this 24-hour blood pressure monitoring study showing chlorthalidone 25 versus 50 hydrochlorothiazide was able to clearly reduce 24-hour blood pressure mean down, highly trended towards greater reduction with chlorthalidone, and certainly nighttime blood pressure was significantly reduced in those patients managed with chlorthalidone compared to hydrochlorothiazide. The benefits of chlorthalidone are shown on this slide. One is the fact that it's a very long-acting drug. With chronic duration dosing, the effect is anywhere from 2 to 3 days, as opposed to 3/4 to 1 day with hydrochlorothiazide. Much longer acting. Indapamide lasts about 36 hours with chronic dosing, 14 hours, as shown here with a half-life. Chlorthalidone has about a 40 to 60 hour half-life. So that chronic dosing, that means, one, it means that it certainly is, in addition to its greater, twice as effective in reducing blood pressure, on a milligram per milligram basis. It is more effective. It should more tolerable to missed doses, which can be reflected in control rates within the clinics. Showed you the data earlier from the SPRINT trial. Here is the data in non-Hispanic Blacks compared to non-Hispanic whites and Hispanics, and essentially showing no racial or ethnic difference in achieved systolic blood pressure in the intensive arm, meaning that in fact we were able to achieve the systolic blood pressure targets regardless of race or ethnicity, with the use of the diuretic of choice within SPRINT and provided by the trial was chlorothalidone, as opposed to hydrochlorothiazide that has been used in many of the quality improvement projects. Those data are similar to what we saw within the ALLHAT trial. Again, in Blacks versus non-Blacks, no significant difference in achieved blood pressures with chlorothalidone. Small difference with the amlodipine, but certainly the ACE inhibitor arm of the ALLHAT trial did show a significant lesser blood pressure lowering with lisinopril. The final data point we'll show on chlorothalidone is this recent publication out of the University of Indiana, which was a trial that looked at the use of chlorothalidone in patients with stage 4 CKD. As you know, generally the recommendation is to switch from a thiazide type to a loop diuretic in patients with eGFRs as between 30 and 40 eGFR. This trial was done in patients with stage 4 CKD, did have a significant number of Black patients, and the results are shown here. Was able to achieve significant reduction in blood pressure in those patients who were randomized to chlorothalidone versus placebo. So that the drug was effective, including getting somewhere about a 15 to 16 millimeter mercury lower blood pressure with chlorothalidone compared to placebo. Do not have a trial yet that will represent a head-to-head comparison between chlorothalidone and hydrochlorothiazide, but that trial is in fact going on. It is a direct head-to-head comparison between 25 and 50 of hydrochlorothiazide versus 12.5, 25 of chlorothalidone in 500 patients. With a cardiovascular outcome, the trial has been fully recruited. The estimated completion date is probably now about 2024, since because of COVID. So that the algorithm that we actually think should replace the use of hydrochlorothiazide. Chlorothalidone should probably be the replacement. We're going to need the higher doses of diuretics in order to achieve the lower blood pressure target. Certainly, the tolerability as well as the lesser effect of missed doses will make it easier to achieve the now lower blood pressure targets and the blood pressure targets over time. And so that the 2017 guideline chlorothalidone was the recommended, preferred over hydrochlorothiazide in that guideline. So just be in touch. So in summary, the evidence supports the use of a lower blood pressure target in nearly all ages in subgroups. We have two large trials showing that the reduction in cardiovascular and all-cause mortality, some evidence for slowing of cognitive decline in dementia, excellent safety profile, even in older age groups. All national and international guidelines recommend the BP targets in this range, and some recommended lower. Minority of individuals may not tolerate or benefit from lower blood pressure target, as risks may outweigh the benefits. These are dementia, orthostatic hypotension. We'll note that that more aggressive blood pressure control actually reduces the incidence of orthostatic hypotension. Didn't show those data, but this was seen in SPRINT as well as in other studies, that more aggressive blood pressure control actually decreases rather than increases the incidence of orthostatic hypotension. Thiazide diuretics are very potent antihypertensives. Chlorothalidone is more potent than hydrochlorothiazide, more tolerant in this doses. They are effective regardless of age, race, and similar levels achieved by race and ethnicity within SPRINT. In patients not controlled on the thiazide, then obviously a CCB is recommended. And with that, I will close and thank you for your attention.
Thank you, Dr. Wright, for that amazing review of a very important topic that affects all of us as clinicians and our patients who we care for. I was interested in just to begin the discussion, I was interested in your review that we didn't stress very much salt intake and the importance of dietary control, even in your paradigm of doing it. Now, I have a friend in Chicago called George Bacris who makes a living out of telling me how much salt I shouldn't take. But I'm wondering, is this no longer such an important issue and that pharmacology overrides it, or is there something else to be learned?
I am a clinical pharmacologist by training, and the studies that I do, lifestyle change is always a function in all guidelines and in fact in all the clinical trials that have been done. So that the fact that I didn't mention it, this was not a look at different guidelines. This was a look at different treatment strategies, focus on drug treatment. So, George Bacris is my friend as well as yours.
I know, that's why I used his name. Thank you, Dr. Wright. I didn't mean to imply that you should have. I just wanted to be sure that the listeners on the call put that into perspective as well. Great. Dr. Preston, did you want to ask a question? You're on mute, sir. Rick, you're on mute.
I think Barry had a question.
Yeah, I'm sorry.
Now Barry's on mute.
There we are. Something we've talked about before, Jack, and thank you for this excellent presentation. That's what I'm looking for in this series of endowed lectureships. The issue is black versus white and why. And the obvious answer that's come up time and again is that we do these studies largely in people who are at the lower end of socioeconomic status. And that seems to be the difference. It's not genetic. Nobody's ever proved anything with the genes. Anything new in this arena?
Yeah, and that's a critical, looked at dietary differences in dietary habits. It does not appear to be the fact. But don't forget, in many of these trials, we're not looking at much difference, even when you compare the one, they either control for socioeconomic status by some measure, probably not as good as we would like. So that I guess the bottom line answer to your question is we don't know. What we do know is that, the major concern is what is the effect on treatment in these different population subgroups, one, and is there a way to equitably both reduce blood pressure as well as equitably reduce clinical outcomes. And I think what we've shown within the trials that I have tried to participate in, or that was to examine that fact and then document whether or not you can eliminate the differences in outcomes in the important subgroups. And so that I think in SPRINT we were able to show that, but using the drug regimen that was in fact used. I think that's
Thank
about,
you.
yeah.
Dr. Zaid.
Yes, hi. Can you talk about how beta blockers fit into the algorithm?
Yeah. There's beta blockers, I think, are relegated, at least in the management of hypertension, to those patients who with either coronary disease or heart failure. I can't think of or for additional blood pressure control. There have been several comparative trials on looking at diuretics versus ACE inhibitors. The ACE inhibitors, the thiazide diuretics have shown greater benefit. Looking at RAS inhibitors versus beta blockers on clinical outcomes, RAS inhibitors fared better. Calcium channel blockers versus the beta blockers. The calcium channel blockers have shown a greater reduction in clinical outcome. So that I think, except for patients with a clear indication of coronary disease, heart failure, they are recommended for blood pressure reduction if you need additional blood pressure reduction.
Thank you.
Dr. Corrales, Pat.
Yes, Dr. Wright, thank you for an excellent talk and reintroducing diuretics as a mainstay of treatment for hypertension. I wonder if you could comment about some of the early studies indicating controversies about potassium lowering, magnesium lowering diuretics, and whether there is continued evidence that we should be replacing potassium in these patients.
Yeah, no question. Potassium needs to be replaced. To the idea of salt restriction within it clearly needs to be accomplished. And one of the things that salt restriction does is reduces potassium loss. Certainly, the more frequent use of, I would suggest, potassium sparing, the spironolactone, particularly in patients where you need for additional blood pressure lowering. I think it's a great add-on drug in patients where you need additional blood pressure lowering and who are going to see greater need additional blood pressure lowering as well as potassium replacement. Then low doses, we talk about 25 to 50 of spironolactone is a very effective drug in preventing or replacing potassium. But in addition, it's also very good as an add-on in patients, obviously in patients with resistant hypertension, but even in patients with who simply need it as another add-on drug. And so that it's, but direct answer, yes, potassium should be replaced. One, and that's always a question that comes up. But what we will say is that when we looked at the incidence of hypokalemia on the clinical trials, it's relatively low. About you can expect to see on average about half a milligram per deciliter reduction in serum potassium in patients who are on 12 to 25 of chlorothalonil. Never seen within the SHEP trial. It was seen within ALLHAT. So that you will see a percentage of patients who will require potassium replacement. It's something you can watch for and correct, and certainly the risk of hypokalemia versus the higher blood pressure or uncontrolled blood pressure is I would take the lower blood pressure in potassium replacement.
Okay, we have 1 minute left. Dr. Preston, the last
Yes.
question.
Yes, I'm off mute. Okay, sorry. You know that appropriately, the interest is shifting down towards lower and lower end of the spectrum in blood pressures. But back in JNC5, there was a category of 210 over 120 as being very severe hypertension. We do have a population. We've have a large population, primarily minority Hispanic patients and Black non-Hispanic patients who come to the emergency room treated for 220 over 120 and then sort of disappear into the community and then come back again. Do you see this type of blood pressure in Cleveland? And if so, are there any special measures that you take or algorithms for this particular population?
Yeah, again, another good reason for drugs, long-acting drugs, so that certainly the amlodipine, long-acting, 60 hours, the chlorothalonil, long-acting drug. But the issue becomes one of stopping what happens when they run out of the medications, which is when they appear, and I think that becomes a greater challenge. That's why we're focusing on 90-day versus 30-day prescriptions. We've convinced the Medicaid to provide 90-day prescriptions. Nearly all the Medicaid plans within Ohio now provide 90-day prescriptions for antihypertensives. And I think that is certainly something that needs to happen. We haven't dealt with, we talk about lifestyle, we haven't dealt with the social determinants of health yet. Which is going to be critical. And so the idea of resources to deal with the social determinants is going to be critical if we're going to achieve control and reduce those circumstances that you mentioned.
Professor Wright, thank you for the most excellent grand rounds. I thank everyone for their participation. Please check the chat for the CME link. And I look forward to seeing everybody next week. And thank you so much, Dr. Matterson, for once again sponsoring this year's Matterson Lecture, which will be here in the Department of Medicine for many, many years to come, just like you. So,
My pleasure.
all right.
Thank you.
Have a nice day, everyone.
Thank you.